Welcome to the Anesthesia and Perioperative Medicine Channel review course. Today, we're building on our Pediatric Anesthesia foundation by tackling two of the most critical and frankly challenging topics in our field. First, we're going to demystify pediatric pharmacology, really getting to the why behind the different drug doses and effects we see in children. Then we're going to dive headfirst into the neurotoxicity debate. What does the evidence actually say about the impact of our anesthetics on the developing brain? And maybe more importantly, how should that change the way we talk to families? So here's our roadmap for today. We'll start with the fundamentals of pharmacology: body composition, protein binding, clearance, because honestly, these concepts explain almost every single dosing decision we make. Then we'll see those principles in action as we look at our everyday drugs, the gases, the IV agents, opioids, and muscle relaxants. We'll finish by tackling that big question of neurotoxicity, tracing the evidence all the way from the initial animal studies to the landmark human trials that guide our practice today. All right, let's start with the fundamentals. And I promise, understanding these core principles isn't just for exams, it is the absolute bedrock of safe pediatric anesthesia. Knowing the why behind our dosing is what truly separates good care from expert care. This is it. This is the fundamental question that underpins this entire discussion. And the answer really lies in these profound physiological differences that evolve so rapidly from prematurity through infancy and into childhood. These differences in body composition, protein binding, and drug clearance, they dictate everything from our initial bolus doses to our maintenance infusion rates. The first major difference is body composition. It's not just that children are smaller, the very makeup of their bodies is fundamentally different. And the most significant factor, especially when we're talking about neonates and infants, is water. Now this is where it gets really interesting. This slide quantifies that difference. A preterm infant can be up to 85% total body water. Compare that to about 60% in an older child or an adult. This has a direct, immediate clinical consequence. For water-soluble drugs, think succinylcholine or most of our antibiotics, this high water content creates a much larger volume of distribution. So the key takeaway, the thing you have to remember, is that to hit the same target plasma concentration, a neonate often requires a larger initial dose on a milligram per kilogram basis than an adult does. It's totally counterintuitive, but it's an absolutely critical concept. Okay, the next key concept is protein binding. Remember from basic pharmacology, it's the unbound or the free fraction of a drug that's actually pharmacologically active. So it stands to reason that any change in the amount of plasma proteins available to bind a drug will dramatically alter its clinical effect. And this is precisely the situation we see in neonates. They have lower levels of both albumin and alpha-1 acid glycoprotein. What does this mean for us? It means that for highly protein-bound medications, a standard dose can result in a much higher concentration of active free drug, and that can lead to an exaggerated or even a toxic effect. A classic clinical example of this is the risk of certain drugs, like ceftriaxone, displacing bilirubin from albumin, which increases free bilirubin levels and the risk of kernicterus in a jaundiced neonate. Now let's talk about getting drugs out of the body. Clearance is determined by the function of our metabolic and excretory organs, and that's primarily the liver and the kidneys. The key point here is that in newborns, both of these organ systems are significantly immature. And this slide illustrates how clearance changes in a pretty complex, nonlinear fashion with age. In neonates, that organ immaturity is the dominant factor. Their cytochrome P450 system and their glomerular filtration are markedly reduced, and that leads to prolonged drug half-lives for agents like morphine. But as children mature, something fascinating called allometry comes into play. Allometry is simply how organ size and function grow at a different rate than the body as a whole. And this means a toddler can actually have a higher drug clearance per kilogram than an older child or even an adult, sometimes requiring more frequent dosing or higher infusion rates. All right, let's move to our first class of agents, the inhaled anesthetics. And let's see how these foundational principles of developmental pharmacology apply directly to the agents we use every single day in the operating room. There are several critical differences to keep in mind here. First, MAC, our measure of potency, isn't static. It's highly age-dependent. It's lower in neonates, it peaks in infants around 3 months of age, and then it gradually declines. Second, children reach equilibrium and go to sleep much, much faster. This is because of a higher minute ventilation relative to their functional residual capacity and also lower tissue solubility. Now, while this rapid induction is a great advantage, it also carries a pretty significant risk. the potential for a more rapid and profound relative overdose if high concentrations are maintained. And what's really interesting about this slide is how it quantifies that risk of overdose. It actually calculates the maximum multiple of MAC that each vaporizer can deliver to a neonate. I mean, look at halothane. Its low MAC and high vaporizer output mean you could theoretically deliver nearly 6 times MAC, which is a huge safety concern. In contrast, for sevoflurane and desflurane, that gap is much smaller, around 2 to 2.5 times MAC. This provides an inherent margin of safety with our modern agents, but it's a powerful reminder of just how quickly a deep anesthetic state can be achieved. So when it comes to choosing an agent for an inhalational induction, the choice is pretty clear. Sevoflurane's low blood solubility allows for a rapid, smooth induction, and its non-pungent odor makes it really well tolerated by children. Desflurane, on the other hand, despite having an even lower blood solubility, which would suggest a faster onset, is extremely pungent. Trying an inhalational induction with it leads to an unacceptably high incidence of breath holding, coughing, and severe laryngospasm. It is simply not suitable for this purpose in children. Now, as we transition from maintenance to emergence, we encounter a common and challenging clinical problem that's pretty unique to pediatrics: emergence delirium. It is so crucial to understand that this is not just a child waking up upset from surgery. It's a distinct neurobehavioral state where the child is agitated, often thrashing, totally disoriented, and completely inconsolable, even by their parents. So how do we manage this? First, know that it's most common in that preschool age group, and we see it far more often with sevoflurane and desflurane. When a child is agitated in the recovery room, the first step is always to rule out and treat any pain. But if you suspect delirium, management is really focused on prevention. Giving a small prophylactic dose of propofol or fentanyl or an alpha-2 agonist like dexmedetomidine right before emergence can significantly reduce its incidence. So the key is to anticipate this in at-risk children and have a proactive plan ready to go before they even wake up. Okay, let's move on to our intravenous agents and see how that developmental pharmacology really dictates their use. The principles of volume of distribution and clearance are paramount here, and they lead to some pretty significant age-based adjustments in our dosing strategies. This table summarizes the specific considerations for each agent, so let's just take a moment and highlight a few key points. For propofol, notice the larger induction dose required in infants. Again, that's because of that larger volume of distribution. But also note the warning about profound hypotension, especially in neonates, and the rare but devastating risk of propofol infusion syndrome with prolonged high-dose infusions. Now, for ketamine, its key advantage is the preservation of cardiovascular and respiratory function. That makes it an excellent choice for hemodynamically unstable patients or for an intramuscular induction in an uncooperative child. Now let's cover 2 more critical drug classes: opioids and neuromuscular blockers. And I'll tell you, our understanding of opioid metabolism in children has evolved so much, and it's led to some major changes in our clinical practice. This slide is critical. It really summarizes how dramatically opioid metabolism varies with age and genetics. Look at morphine. Its clearance is significantly prolonged in neonates. That's due to immature hepatic conjugation pathways, and it only reaches adult levels at around 6 to 12 months. This forces us to use cautious dosing and longer intervals. Now, contrast that with remifentanil. Its metabolism by nonspecific esterases is completely independent of organ function, and clearance is actually more rapid in neonates. This makes it an incredibly useful agent for providing profound, titratable analgesia without having to worry about prolonged post-operative respiratory depression. I really want to draw special attention to this. Codeine and tramadol are both prodrugs. They rely on the cytochrome P450 2D6 enzyme for conversion to their active metabolites. Now, the activity of this enzyme is genetically determined. Some individuals are ultra-rapid metabolizers, meaning they convert these drugs to their active forms very, very quickly and efficiently. In these children, a standard dose can lead to a toxic overdose, resulting in life-threatening respiratory depression. This has led to an FDA black box warning against their use in many pediatric settings, particularly after tonsillectomy. For muscle relaxants, succinylcholine, remember, requires a larger mg per kg dose in infants because of its larger volume of distribution. However, its use carries an absolute contraindication in children with known or even suspected muscular dystrophies, all because of the risk of fatal hyperkalemic cardiac arrest. And it's just impossible to talk about relaxants now without mentioning Sugammadex. Its availability has truly revolutionized reversal. The ability to rapidly and reliably reverse even a profound rocuronium or vecuronium block represents a major leap forward in safety, especially when we're managing a difficult pediatric airway. Okay, so let's briefly summarize what we've covered on pharmacology. The three big takeaways are 1. Dose up on a mg per kilogram basis for water-soluble drugs in neonates. 2. Be cautious with highly protein-bound drugs. And 3. Remember that toddlers can clear drugs surprisingly fast. Now, while we focused on these immediate drug effects, there's a much larger, long-term question that has dominated our field: the potential impact of our anesthetics on the developing brain. This statement truly captures the heart of the initial concern. A large body of preclinical research, mostly in rodent and primate models, showed that exposure to nearly all of our commonly used general anesthetics during a critical window of brain development could trigger widespread programmed cell death, or apoptosis, and lead to lasting deficits in learning and memory. But this raised the absolutely critical question: how do we apply these findings to human children undergoing surgery? There are major challenges in translation. The animal studies often used much higher doses of anesthetics for much longer durations than we do in typical clinical practice. Most models lacked the concurrent surgical stimulus, which we know has its own profound neuroinflammatory effects. And of course, there are inherent differences between species. So let's look at the timeline of how human researchers tried to answer this question. The first wave in the 2000s consisted of these large, retrospective, population-based studies. And while some of them suggested a correlation between early anesthetic exposure and later learning disabilities, they just couldn't control for all the confounding factors. This really paved the way for more rigorous, prospective studies, the most important of which are the PANDA study and the GAS trial. These two trials have provided the best human evidence we have to date. The PANDA study was a sibling-controlled cohort study that found no difference in IQ or other neurocognitive domains between siblings who had a single, brief anesthetic before age 3 and their unexposed siblings. And the GAS trial, a landmark randomized controlled trial, compared general to regional anesthesia for infant hernia repair. At both age 2 and again at age 5, they found no significant difference in neurodevelopmental outcomes between the two groups. So, with this seemingly conflicting data between the lab and the clinic, what is the current consensus? And maybe more importantly, how should this evidence inform our daily practice and the critical conversations we have with parents? And this slide perfectly captures the central dilemma we face as clinicians. On one hand, the basic science is undeniable, and it remains a source of concern. But on the other hand, the best prospective human trials we have are largely reassuring, at least for the specific scenario they studied: a single, relatively brief anesthetic for a minor surgery in an otherwise healthy child. So our primary role as clinicians is to synthesize all of this into clear, evidence-based recommendations for families. And this is the consensus from major pediatric anesthesia societies worldwide. First, we have to be honest and acknowledge the uncertainty. Second, we can confidently reassure parents that for a single, brief anesthetic, our best evidence shows no signs of harm. Third, and this is the most important part, the known risks of delaying a medically necessary surgery far outweigh the theoretical and unproven risks of the anesthetic. And fourth, we have to acknowledge that the jury is still out on prolonged or multiple exposures, and this remains a vital area of ongoing research. To conclude, I'll leave you with this provocative thought that is really guiding the next phase of research in this area. For years, we have focused so intently on the anesthetic drugs themselves, but perhaps the question was too narrow. We're now beginning to explore the powerful role that the surgery itself, the inflammation, the stress response, the pain pathways, plays in neurodevelopment. It may be that the underlying condition and the surgical intervention are far more important variables than the specific anesthetic technique we choose.